Good afternoon, good morning, good evening, everyone, from wherever you're joining us from. And thank you so much for joining this March session of the ECHO sessions. And we are really grateful to the Gates Foundation for the funding to continue with these sessions. Today, we're really excited that we are kicking off the month of March with a session on TB. As many of you are aware, the 24th of March is World TB Day. And this year, the theme again is, yes, we can end TB, but we are adding, we can act now, commit now, and invest now. And in line with that need to act now, we are going to have a presentation today that will talk about phenotypic drug susceptibility testing. We know that this is one of the pillars of the NTB strategy, but there has been gaps in access to phenotypic drug susceptibility testing across many countries. So we are really privileged today that we have a world expert on things to do with culture and drug susceptibility testing, all the way from Antwerp in Belgium, Prof. Lynn Richholtz. And before I give a brief bio of Prof. Lynn, I just wanted to touch on some key housekeeping items. So you'll see that many of you are not able to unmute yourselves, but you can participate in the chat session. And this session is going to be for an hour. We will have the presentation for about 30 to 45 minutes, and then we'll have time for question and answers. At the bottom of your screen, you can see a Q&A section. So you can put your questions in that box, and we'll get to your questions during the question and answer session. We also have interpretation services. So if you click on the globe or the world map on the bottom of your screen, you can select the channel you would want to listen in, where French and Portuguese are available. So you can select the appropriate channel. We will also have the slides and the recording available for you at the end of the session, and you'll also receive an email about downloading your certificate of participation. So again, thank you so much for joining us. And as I mentioned, we have today with us Prof. Lynn Richholtz from the Institute So we have Professor Richholtz from the Institute Tropical Medicine in Antwerp, Belgium, and she'll speak to us today about the general concepts of phenotypic drug susceptibility testing. Professor Richholtz has a PhD in biomedical sciences, and she joined the mycobacteriology unit of the Institute of Tropical Medicine, Antwerp, in 1989. And where she is a senior technical expert, she's a technical advisor of the supranational National Reference Laboratory. She's a coordinator of the WHO's ISO 17043 accredited EQA program for TB, and she's the manager of the BCM or ITM also a member of the Global Laboratory Initiative Core Group. She's a vice president of the European Society of Mycobacteriology, and she serves on the technical advisory group of the WHO Euro region, as well as various scientific expert committees. So we are really in the presence of great company, and it's going to be a wonderful session. So with that, I will hand over to you, Prof, and welcome. Thank you.
Thank you very much, Lucy, for these kind words and nice introduction. Good afternoon to everybody. Bonjour, bonsoir à tous. Je vais commencer à partager mon écran. So I will present on behalf of the Global Laboratory Initiative. And in short, the Global Laboratory Initiative is part of one of the 8 working groups of the Stop TB Partnership. And the core group has a role to have an independent technical expert advisory group to the WHO. So the mission of the GLI is to serve as a collaborative platform for the development and uptake of practical guidance and tools for building and sustaining high-quality TB diagnostic networks. And we have multiple topics that we touch upon in the GLI, and one of them is implementing WHO policy guidance on TB diagnostics and laboratory strengthening. And the topic of today fits in that implementation policy guidance. So if you want to know more about the GLI, you can scan the QR code or go to the link. And on the website, you will find the working group training packages. And one of the training packages is the phenotypic drug susceptibility testing. In here, you will find 2 PowerPoints, one with general concepts highlighting a bit the theoretical background, and a more practical training with details on how to prepare stock solutions, working solutions, and so on for each of the methods used in TB drug susceptibility testing. So today I will mostly talk about the general concepts and a little bit on troubleshooting and errors that can be made in the lab. So this is on the drug susceptibility testing general concepts. What we will address is drug resistance development and occurrence, some concepts of phenotypic drug susceptibility testing, DST, MIC, ECOF, clinical breakpoint, proportion methods, and so on, good practice and quality assurance, some troubleshooting, and if time allows, something about hetero and cross resistance. Just to inform you that the content of this presentation and the ones that are on the website are based on the latest recommendations by WHO. So GLI indeed serves to support implementation of WHO guidance. And more particularly, we are basing our information on the operational handbook, module 3, and the web annex C, as you can see here. So how is drug resistance developed, and what about the occurrence? I'm pretty sure that most of you are aware that drug-resistant TB is still a worldwide problem. Nevertheless, you can see that there is an uneven distribution of the proportion of drug resistance in the world. On the left-hand side, you can see the incident cases from 2023, and it represents the estimated number of multi-drug resistant TB, MDR, and RIF-resistant TB, RR-TB. And you can see that in India, China, and other Asian countries, there is a higher absolute number, but of course, there's also a higher absolute population number. But also, if you look at the prevalence, the percentage of RIF resistance amongst previously treated patients, then you can see that there's quite a lot of higher percentage in the former Soviet Union republics. So TB, some of you in the audience may still know the period where the first drugs were introduced, although I think majority has not experienced this, and it was in the 1940s. We had streptomycin, isoniazid, PAS, and so on. And only in the 1980s, we had the blue box, which represents what we call the short course chemotherapy for drug-susceptible TB. And it comprises isoniazid, rifampicin, pyrazinamide, and ethambutol. And then more and more drug resistance arose. And since 2019, the BPAL regimen came into force to treat MDR and RR-TB patients, so with bedaquiline, pretomanid, and linezolid. There are alternatives as well. So anti-TB drugs, what do? They act on different populations during a regimen. So if you compare the bacillary populations in a patient, and then over time, you look during treatment to months 2 to 6 and so on, you can see that in the beginning, we have a large population of TB bacilli, of which most are metabolically very active, which is called population A in this graph. And the bactericidal drugs like isoniazid, rifampicin, fluoroquinolones, bedaquiline also are very active against these rapidly metabolically active populations. There are some that are less active and have spurts of metabolic activation. And drugs like, again, rifampicin, fluoroquinolones, and bedaquiline can act on these bacilli as well. And then over time, it's the most hard to kill are those that have a very low metabolic activity and that reside inside macrophages and at the acidic pH. And there, pyrazinamide plays an important role. So you are all aware that there is combination therapy applied for tuberculosis, and it adapts to the drug resistance profile. So the standard treatment, as I said before, is isoniazid, rifampicin, PZA, and ethambutol. And this is given to patients that have no indication of rifampicin resistance. But as soon as there is a diagnosis made of rifampicin resistance or rifampicin and isoniazid resistance, MDR, then we need alternative treatment regimens. And now the BPAL regimen is based on the core drug bedaquiline together with fluoroquinolone, pretomanid, and linezolid. The fluoroquinolone depends on whether the bacilli of the patients are found susceptible or resistant to the fluoroquinolone. But once again, if the resistance develops for the fluoroquinolones, we determine the bacilli as being pre-XDR, so MDR plus resistant to fluoroquinolone. And in worse cases, where also bedaquiline and or linezolid become resistant, then you will have an XDR patient. And how to treat these, that's still an open question. So how does the resistance occur, is generated? So imagine that you have a patient that has isoniazid susceptible bacilli. Some of them may be resistant, and over time, if you give them inappropriate treatment, you will give selective advantage to these isoniazid resistant bacilli. And in the graph below, you can see that the proportion of isoniazid resistant bacilli will increase. It becomes a completely resistant isoniazid resistant strain. The same can happen again with bacilli that are resistant also to rifampicin. And again, after selection, you can have then an MDR-TB strain. So it is a cumulative process, the acquisition of drug resistance. So the factors that influence the development of drug resistance is, first of all, treatment with inappropriate drugs or combinations or dosages of the drugs. That can be due to interruption or irregular treatment, incomplete treatment, but also because the bacilli do not respond very well anymore because they are not so active metabolically anymore. They came into dormancy. It can also be that you have not a good penetration of the drugs in a specific site of the body, in the caseous tissue or in the brain when there is a barrier for the drugs. It can also be that you have in the sites where the bacilli are, you have then a lesser concentration of the drug, so suboptimal drug concentration. Or it can do because the patient has underlying conditions which cause an impaired drug absorption at the intestines and blood. So the drug-resistant mechanisms, there is many in the bacteriology. There is changes in the cytosol. There can be problems in decreased penetration or in efflux pumps along the level of the cell wall. So the cell wall is intrinsic resistance causing in MTB complex. But the most common resistance mechanism in M. tuberculosis complex is on the DNA level. So you have changes in the genes, in the target genes, or in enzymes that have to change the prodrug to an active drug. So DNA changes. That's a little bit of background. Let's go to the phenotypic concepts now. If we want to know whether a patient has drug-resistant bacilli or not, we can do molecular tests, or we can check on culture-based methods on solid medium, where we count colonies, or in a liquid medium, where we measure the metabolic activity, like in MJIT, for instance. So typically, we test just one concentration, and this is called the critical concentration. It separates susceptible from resistant bacilli and wild type from mutant bacilli. The most commonly used method is the proportion method. And there's also the absolute concentration method, but now I will focus on the proportion method. So that's the standard DST, as we call it. But you can also do MIC determination. And typically, you test then multiple concentrations of the drug, and these are occurring in twofold dilutions. So the minimal inhibitory concentration, what is that? That's the lowest concentration of the range that you are testing that prevents growth of 99% of the microorganisms in your sample, in your strain. So in this case, it may not be very clear, but so there is no growth here, and it says 4 microgram per milliliter, not 2, not 1, but 4, so 4 is the MIC in this case. That was one strain, but if you test multiple isolates, then you can have a kind of distribution. So in this graph, you have the number of isolates in the y-axis and the MIC values on the x-axis, and then you will have a normal distribution of MIC values if you test a sufficiently large number of strains. So indeed, we can have here the blue ones, which are phenotypically wild type and susceptible. They do not have mutations. But then if we go to test the resistant ones, the ones that have mutations, we see another curve occurring. Apologies. And so what is now the critical concentration? That's the lowest concentration of an agent that will inhibit growth of 99% of your isolates tested. In this case here, the square represents 99% of the phenotypically wild type, so the critical concentration is just above. So this is when we talk about multiple strains that are being tested. It's also possible that you do not have just one curve that is representing the resistant strains, but there may be another mechanism, a second type of mechanism that gives you higher MIC values if you test multiple strains with that mechanism. So sometimes it's possible that those with mechanism 1 are still likely to respond to the treatment, albeit with a high dose that is given or not. And that the other ones are less likely and they probably have a therapeutic failure. So the concentration of an anti-PD drug, which defines an MIC above the critical concentration, so the critical concentration is separating susceptible versus any resistant. So that's a second concentration that separates the strains that are likely to respond to treatment versus those that are likely not to respond to treatment. So in this case, we define the clinical breakpoint here. For TB, this has only been defined for moxifloxacin. So we talk about low versus high level fluoroquinolone resistance. And this can also be linked to various types of mutations in the gyrase A gene, like alanine 90-valin is low level resistance and aspirin 94-glycine is high level resistance. But in order to be of any clinical significance, it's important that we also know the pharmacokinetic and dynamic data. Can a higher dose be obtained? Is a higher dose safe? And so on. So it has no meaning to define a clinical breakpoint if you cannot higher your dose until what is needed. So we sometimes also mention the critical proportion. Remember in one of my first slides, I said that 99% of the bacilli are killed at a certain concentration. And this is what we mean with the critical proportion. And indeed, for TB drugs, we usually apply a 1% proportion for first and second line drugs. The only exception is pyrazanamide testing in MGIT, where a 10% critical proportion is applied. Hence, you also make your control a 1 in 10 dilution, not a 1 in 100 dilution. So how does it look like doing DST? So typically you have your tubes, you have the tubes with no antibiotics added, and you have a tube in which you have antibiotic added at the critical concentration of that specific drug. You inoculate your drugs with a specific concentration and your control with a 1 in 100, except for PZA, which is not done on solid medium anyway. And then 4 to 6 weeks, you count the colonies. Given that the 1 in 100 bacterial suspension that was inoculated represents 1% of your maximal possible growth, we can say that whatever drug-containing tube has less colonies than the 1 in 100 control, the strain is considered susceptible. Whereas below, we can see that there is more colonies growing on the drug-containing tube, so we define it as resistant, because more than 1% of the bacilli is resisting the drug. The most commonly used phenotypic DST media and systems are in TB, the solid media Löwenstein-Jensen and Middlebrook agar, which can be in a normal incubator. For agar, sometimes CO2 is installed at 2.5%. You do manual reading and 4 to 6 weeks. The 6 weeks is important, particularly to detect these slowly growing strains, and then we think about the RPOB borderline mutations of which you may have heard. And then in liquid medium, in MGIT, for instance, there is an increase in fluorescence if you have a decrease in oxygen, so it means that something is growing. And when we have a pure culture, we assume it's MTB, it's growing. And then you will have the drug-containing tube. If it has lower than 100 growth units, it's susceptible. If it's equal or above, we consider it as resistant, or at least the system makes the automated interpretation. So what about MIC? I already explained that you test twofold dilutions, and here you can see the gradual increase of the concentration in the purple drugs. But in principle, you do the same in terms of inoculation. You have your control, 1 in 100, to which you compare your growth. So in this case, the first tube that has less growth than the control is the 4 microgram per milliliter. So that's the MIC for this example here. So MIC values of an isolate can also be translated in the binary or S result, like if we had done just critical concentration testing. The critical concentration of a drug is always included amongst the concentrations that you test in MIC. And then you can say, if your MIC value is below that critical concentration, it's susceptible. If it's equal, it's susceptible. If it's higher, it's resistant. So that's how you can translate MIC into binary result as well. MIC values may vary with the medium used because of the protein binding, for instance. So rifampicin, you may all know that in Löwenstein-Jensen medium, the critical concentration is 40 microgram per milliliter, while in MGIT, the critical concentration is 0.5 for the same drug. So if you find on MIC testing on LG medium an MIC of 10, it means susceptible. If for rifampicin, the same, you have a strain, another strain, which has an MIC of 10 in MGIT, this is clearly resistant because it's above your critical concentration. So this shows that MIC of 10 microgram per milliliter doesn't say anything. You always have to mention the medium that is being used. So ECOF, you may have heard of ECOF as well. ECOF stands for epidemiological cutoff. And again, if we have been testing more than 100 strains, or at least 100 strains from 5 different laboratories, then we can see again that the MIC value is just above 99% of the phenotypic wild type strains. And very often, if the drug resistance mechanism is not known, the ECOF is used as surrogate to determine the critical concentration. So you'd start testing with 100 strains from different lineages, different geographical areas, and then you define where your ECOF falls, and that's what you use as critical concentration. So the ECOF does not change by sampling if you do it well. If you choose your strains that you select in the beginning with a broad variety of geographical origin and phylogeny, then it will not change over time. Yeah? It may change again with testing medium, of course, because of the binding of the drug to your medium, just like the critical concentration. And then the clinical breakpoint, it may change over time if new resistance mechanisms occur, or if there is new indications of that safety on using a higher dose, for instance. But that's not very common, let's be honest. So why would we use MIC versus critical concentration? For the majority of TB drugs, we have a clear separation, but sometimes here you can see the green ones, the susceptible ones, and the yellow ones, mechanism 1 of resistance, and there is an overlap. So you have your ECOF or your critical concentration falling inside the distribution of your resistant strains. And then actually we should define an area of technical uncertainty. And we should say that the result is uncertain. We do not know. In TB world, at this moment, this is not very commonly used. It's R or S, but actually MIC testing can give you a better view on what exactly is the level of resistance of your strain. So that's one of the advantages. Also, it gives you a nuanced information on the phenotype, and it will help us to better understand the association between genotype and phenotype on a large number of strains. So the ECOF encompasses approximately 99% of the phenotypically wild-type strains, as I have shown. So if you are in an area where there's a very low resistance prevalence, yeah, then you risk that your positive predictive value of binary testing, phenotypic DST standard, that you will have more false resistance. And doing an MIC can give you then a more precise idea of the resistance. And also, as particularly for the new drugs now, for bedaquiline, we don't really know what the critical concentration means in terms of treatment outcome and in vivo resistance. So doing MICs gives you more information also over time in the patient. If you see an increase, what does it mean? There's also sometimes that we have different outcomes of MIC values depending on the lineage. And you may be familiar with the different lineages, 1 to 10 we are now, and they have a different distribution in the world, as you can see on this map. The data shown in this chart here, in blue, we have M. africanum. You can see the MIC for pretomanid is low. Canetti has a higher one, but Canetti is not very common. But then you have here the other groups, like the light green L2, 3, 4, and 7, have a lower MIC distribution compared to L1. And this work has been confirmed by Praha Rupasinghe, showing exactly the same results with for group lineage 1 having higher MICs. So it's still to be seen in real life what it means in terms of efficiency of the drug in the patients that are infected with L1 versus L6 or other lineages. And this is also the reason why at this moment 2 concentrations are recommended by WHO. So the UCAST method, just for your reference, it's the European Committee on Antimicrobial Susceptibility Testing. It's now considered the reference method for MTB complex in broad microdilution. So it's in microtiter plates with Middlebrook 7H9. And this method is used to calibrate new phenotypic DST methods and MIC methods in other formats, and particularly also for new drugs. And you can find more information on this link here, and the latest version is from last month. So how does it work? You have, in the outer wells, you have water, and then you have the drugs that are serial dilutions, twofold dilutions. From solid medium, usually you start to make your dilutions, and then you inoculate your 10-2, which is considered the growth control 100%, and you have your 10-4, which is the growth control 1%. And then you can start inoculating with your TB in this manner. So basically you have in pink the drugs and where you have the different concentrations. You have your growth controls, and they should both be having growth, so the 1% and the 100%. And you should not have any growth in your negative controls. So it's important now that the 1% has been included. As soon as you have 1% growth, you can read your results. So let's go to good practices in quality assurance. So these are the recommended critical concentrations. For the group A, all of them have defined concentrations in MGIT. But for bedaquiline, for instance, we have no for LJ, and we will never have, because there is too much protein binding. So it's not recommended to use bedaquiline testing lunchtime. And also for bedaquiline, we should use polystyrene or glass tubes for preparation of the stock and of testing because of the plastic binding of bedaquiline to the plastics. You can also see that for group B and some of the group C, there is no recommendations at all or hardly any recommendations. There is a recent update though for cycloserine, but very limited data though. And then we can also see for clofazimine, MGIT is recommended, but we must admit that even amongst supranational reference laboratories and national reference laboratories, results vary a lot, flip-flopping from resistant to susceptible, which has to do with this overlap in MIC values of susceptibility, the non-stability of the drug, so many problems for clofazimine testing. The drug concentrations and preparations, in case of commercial tests, you follow the instructions, for example, in MGIT. In case of in-house preparations, the stock solutions usually are at 10,000 microgram per milliliter. So the higher the concentration, the more stable it remains when you conserve it at -20 or -80. And you have specific solvents, very often DMSO or sterile water. And this is all described in the WHO manual and in our practical guidance PowerPoint as well. They should not be refrozen after thawing. So you make aliquots and then you use them. The working solutions, there you have lower concentrations and therefore you do not store them after you have used them. And you have also to make them in such a way that you don't add large volumes, because that changes your growth medium, that dilutes your growth medium too much, or it increases too high concentrations of the solvents that can be toxic. So the potency of the drug, this is an important one. So the powders that you buy, they are pure, in the sense that they are chemically tested, that there is no contamination of other reagents or dust or whatever. But pure does not mean that everything in your drug. Sometimes the drugs come like a salt, like bedaquiline is a fumarate, it's a salt. So if you weigh 1 milligram of bedaquiline powder, you don't weigh 1 milligram of bedaquiline active component, because you also measure the fumarate. So, and that's why you have to apply the certain rule here that takes into account the potency of the drug. And this potency is defined based on experiments in vitro and vivo. It depends on the production of the lot sometimes. And so it should be checked for each of the lots of powder that you buy. The information is sometimes mentioned on the bottle, sometimes it comes with a certificate. And then you apply the volume that you want to prepare of the stocks of concentration, the concentration, and you divide by the potency that is mentioned or that you have the information of. This is the case for bedaquiline, amikacin, and so on. You definitely have to apply this. Quality assurance. Why should we do quality assurance? First of all, make sure that we have accurate and reliable testing, because we are going to serve our clinicians and the patients to guide treatment changes. Also, it's a requirement if you have ISO accreditation. So what do we aim for with quality assurance? Is that we want to detect, evaluate, and correct errors. Errors that can be due to system failure, environmental conditions, operator performance, anything that can happen. And we want to detect them before we send the result to the clinician or for the patient. So yes, because sometimes your product may be mishandled during shipment, or your laboratory is not performed accurately because of the incubator is out of temperature, and so on and so on. So how do we do that? A comprehensive and systematic quality assurance program should be implemented. And this can be done through support from supervising supranational reference laboratory or guidance from other instances. And key activities, first of all, training. Phenotypic DST is not difficult, but you have to take into account so many different steps and be so secure that you need solid training for people to make the correct interpretations. Of course, instrument and equipment maintenance and verification. Method validation, you have to check with the correct set of strains in your setting, with the powders that you have, with the medium that you have, whether it works or not. And then you continue doing that by checking each lot that you buy, each new lot of powder, each new lot of medium. You do your quality control. And finally, what's very important also is that you participate in external quality assessment by proficiency panel testing. And again, your SRL or another instance, there are multiple instances, and on the GLI website, there is also an EQA dashboard that you may consult. And there you can find a whole offer of EQA proficiency panel testing. There's also quality indicators monitoring. And what do we mean by that? Here are some mentioned. So you have to use your common sense and also to know your epidemic, meaning that it's weird to have isambutyl monoresistant. It's weird to have, let's say, bedaquiline monoresistance. That should not happen in your setting. It's not a normal result. Your setting may be specific, but still you have to know what is expected result and what is not expected result. So both in terms of the number of contaminated DST or uninterpretable DST should be below 3%. If not, your cultures may not be pure. And then you have the laboratory turnaround time that you also have to monitor. So these are things that you can monitor. You look at the results. Do we see unexpected results? Do we have low contamination and uninterpretable rates? So I already mentioned QC to be done on all new lots with each batch. If you do batch testing, it's good to take the H37 RV strain along every week, for instance. Yeah. And then we have the reference strains, The pan-susceptible is the most important, and usually we take the H37RV. It can also be others, but that's the most commonly used. You can also test specific drug-resistant strains, but it can be very useful for implementation validation and to check if you have some unexpected results, but to do them all systematically is quite demanding. So, of course, your QC can be prepared from MJIT tube or solid media, and the suspensions must be homogeneous. That's for all DST, right? So these are the control strains that are recommended by WHO that can be obtained from the American type culture collection or from the Belgian culture collection. And it needs to be noted that for clofazimine, there is a strain mentioned, but it's a tentative strain. And we have noticed that even this reference strain is causing problems. When we used it in SRL EQA proficiency panel testing, around 50% of the labs reported resistant and the other susceptible. So at this moment, we do not have a reliable clofazimine resistant strain. So troubleshooting, very often we see in MJIT X400. X400 means that you have too much growth. Your inoculum has been too heavy, or there was a contamination. So you have to make sure that you prepare the McFarland correct if you start from solid medium, or that you check the purity of your primary MJIT culture by doing blood agar, Ziel-Nielsen staining, checking visually, do I see flux or do I see like turbulence, and so on. Sometimes if you have very high growth units in your primary MJIT, then it can also cause X400. Same for X200. Then you have too little growth. You didn't have sufficient inoculum. It's possible that you used too old cultures, for instance, or you prepared your McFarland in an inappropriate way. It was not sufficiently homogenized with the beads, and then all your bacilli are at the bottom and you transfer water. So yes, it's important to use fresh, pure, certified cultures. And the same actually is true for LJ. Again, you can have contamination because it was not pure, or because your tubes have been prepared in a non-aseptic way, or you manipulate it in a non-aseptic way. So all these kinds of quite logic things are important. So what we also recommend is to include para-nitrobenzoic acid, PNB. So the PNB allows you to differentiate between non-tuberculous mycobacteria, NTM, and Mycobacterium tuberculosis complex. So it's always good practice to include PNB in your DST. It can be in MJIT, it can be done, and it can be done on solid medium. It can even be done in microtiter plate, always at a concentration of 500 microgram per milliliter. Here we see another summary of common errors and their impact. This was a slide that we borrowed from Harold Hoffman. And so if you make calculation errors in your drug powder stock solution preparation, you can have either that the drug activity goes down or up depending on what you do, and it can generate false resistant or false susceptible. You forgot to take into account the potency. You used wrong pipettes. You had incomplete dissolution, so you were preparing your medium or your drug stock concentration, and it was not entirely solved. So you can see that there's many steps that can go wrong, and that's why training is so utmost important. You can see that most of these errors result in false resistance. Yeah, and that's why it's so important to have the H37RV, which is a pan-susceptible reference strain, It's so important to have that as a QC strain, because most errors are false resistance, and you will detect it with H37RV. So I come very briefly to two last slides. So heteroresistance, what does it mean? The simultaneous presence of resistant, being mutant, or susceptible, being wild type bacilli. This can be due to mixed infections. People can be infected with both a susceptible and resistant strain, or, as I explained earlier on, because you have ongoing evolution. But it also means that the patient can spit at one point susceptible bacilli, or a mixture, or resistant bacilli. So that can vary across sputa. And also the different techniques that we use for detection of drug resistance, like expert, Sanger sequencing, LPA, NGS, they have different limits of detection. Now, phenotypic DST, what we have just discussed, is good, because remember, we have this critical concentration of 1%, and we will detect all bacilli that 99% of the bacilli that are susceptible. Cross-resistance occurs when organisms are being resistant to a drug without having been exposed to that fluoroquinolones that belong to the same class. So they are resistant to levofloxacin, moxifloxacin, ofloxacin, but it can also be amongst drugs from different classes, like bedaquiline and clofazimine, because they have the same drug resistance mechanism through the efflux pump regulator. But also isoniazid and ethionamide, because they have the same drug resistance mechanism through the mutations in the promoter region of the INH-A gene. So I'm running late, I think, and this is my last slide. Thank you for your attention, and I'm open for responding to your questions.
Thank you very much, Prof. This was a really detailed presentation on phenotypic drug susceptibility testing, and you've definitely given us a lot to think about in terms of making sure our procedures are set up correctly, and we've set up quality control procedures and are participating in EQA. So we have a number of questions in the Q&A, and I will start with one that has just come in from Mohammed. And he asked that sometimes we found bedaquiline monoresistance in phenotypic DST. How do you interpret this? If you found phenotypically bedaquiline resistance, but no mutation in NGS, what can be done in this case?
Thank you for the question. I think it's an erroneous phenotypic result. First of all, because epidemiologically it's very unlikely, because bedaquiline is a newly introduced drug. So we don't expect much bedaquiline resistance to be around. And particularly if we do not have any molecular mechanism or molecular data to support your finding, I think it's very likely that you have a mistake. And then you need to check all these things. Did you use polystyrene tubes or glass tubes? Was your stock solution of bedaquiline, which can only be kept for 3 months? So most stock solutions can be kept for 1 year, but bedaquiline, it's only 3 months. They do not pass that preservation date. So I say it's very likely that it's wrong, but occasionally you may have, but then it should be supported by molecular data, because we know that there is naturally occurring mutants as well, but they are not very common, and you should find at least a mutation. So I think going over the list systematically of all the things that are recommended by WHO and in the GLI PowerPoint on practice, did I tick everything, and then test again?
Wonderful. Thank you, Prof. The next question is from Davis Kochaka, and he says there are strains of MTB carrying RPOB1491F mutations, which are known to be missed by traditional midget culture prediction due to the concentration of reef used in these methods. In these instances, how can DST be done to detect these strains?
Thank you. Indeed, this is an issue of the RPOB borderline mutations, and 491 fill-in mutation is one of them, which is very prevalent in Eswatini and South Africa. And if you do solid medium testing on Loewenstein-Jensen, but also on agar medium, and allowing for 6 weeks of growth, usually they will show up as resistant. You may still miss, but usually the 491 fill-in is well detected on solid medium and slow growth allowing.
All right, thank you, Prof. And I see hands going up, but please could you put your questions in the Q&A and we will try to respond to as many as we can. Thank you. The next question is from Guy Arnaut. He says, thanks, Prof, for the clear presentation. I want to know if we have to consider PDST results instead of genotypic ones in case of drug resistance. Also, regarding the lack of knowledge and molecular tests for bedaquiline in low resource settings, why do we have this drug? And where do we find bedaquiline drug for DST?
Okay, thank you. Very important questions. First of all, why do we have bedaquiline in the countries? I think it's an important drug to cure our MDR-TB patients, and we should not withdraw it, I think. But it's very unfortunate that we started using it without having phenotypic DST and or genotypic DST having in place before it has been rolled out. So that's a lesson learned that for future new drugs, this should go hand in hand. Testing capability and capacity and rolling out of the drug. Now, with regards to, so I'm lost thinking now. What was the question? It was.
So the other part of his question was where to get the drug for.
Okay. Yeah. So the drug, it has been very difficult. It was available through the BEI, but I think last month there was communication from the Global Drug Facility that now it is available in larger amounts through the Global Drug Facility. So basically where you place all your orders. And why was it important to have these larger volumes? Because as I mentioned, bedaquiline stock solutions can only be kept 3 months. And if you had one vial and then it was gone after 3 months, you had to order again. But now they have adapted. So that should be solved, that problem. And I think there was a third part of the question. No?
Yes, there was, but somehow it has disappeared from my screen.
Okay.
I apologize. So the next question says, oh no, I found it. So it says, I want to know if we have to consider PDST results instead of genotypic in the case of drug resistance.
Yeah, very important. Yeah. So there's few drugs for which we say that resistance testing molecularly overrules phenotypic testing, and that's for rifampicin. So rifampicin, we say clearly if you find these mutations and phenotypic susceptible, we say it's resistant. Now for bedaquiline, we are like in the dark with the mutations. There is so many in this efflux pump-driven mechanism that we do not know the significance because we have few strains only for each of the mutations. So I agree that for bedaquiline, at this moment, phenotypic DST is at least as important or more important. And to gain knowledge, we would like everybody to do MIC testing for bedaquiline. But of course, this is not really feasible. But that would be great. If you are able to do MIC testing, please do. But otherwise, you have the binary phenotypic DST, which I would think guides more than the molecular at this point.
All right. Thank you. Very clear, Prof. And I'm even getting questions about when we are having a next session of targeted next generation sequencing, and that is planned. Another question says from Miriam, could you elaborate a bit on resistance to pyrazinamide? I understand it is the only drug active against population C. How common is resistance compared to rifampicin and isoniazid?
Thank you for the question. So pyrazinamide testing is only done in MGIT. There have been some alternative testing with nicotinamide and other platforms and so on. MGIT PZA testing was supposed to be unreliable long time ago. Then we thought, okay, now it is solved, and we had much better EQA results across SRLs and also amongst NRLs. But then since last year, again, an issue popped up. So at this moment, MGIT PZA testing is troublesome, and there have been communications from Becton Dickinson on this, and they have problems with their production. So at this time, I would say it's not really reliable. But in general, the data we have from some surveys that were done in the past, also based on PNCA sequencing, which is easier to do than phenotypic testing. We know that about half of the rifampicin resistant strains are resistant to pyrazinamide. That's more or less. In the rifampicin susceptible ones, it's lower. And we all know that for Mycobacterium bovis, it's always resistant to PZA.
Yeah, and I think I saw a report from Ethiopia also showing high prevalence among retreated cases. So definitely something to be looking at.
Okay.
The next question is again from Miriam. She says, could you explain a bit more about the risk of false resistant results in settings with low resistance prevalence and the need to do MIC in such a setting? And what do you consider low prevalence?
Yeah, I think the low prevalence, I'm not a statistician. I think there the low prevalence that was defined is that if it's below 1%, that was the threshold to say if it's below 1% and you have then this area of uncertainty for these drugs where it's overlapping, then it becomes an issue to have false resistant results. But I don't know if Sushil Pandey is on the call. No. Sorry,
yeah, it's a
I
difficult.
think that's the case. Yeah.
Yeah. We are only left with 2 minutes. And we have a lot more questions in the Q&A session segment, but then we will send the questions we have not addressed today to Prof. Lin, and she will respond to them, and then we will share that transcript over to you as we share the slides and the recording of this session. And I once again want to thank Prof. Richards for making the time to present to us and to show us the importance of developing quality assured processes in our labs to ensure access to drug susceptibility testing, particularly for the new drugs that do not yet have any molecular tool. So if you have any last remarks, Prof, I ask you to give them to, and then we can close the session.
No, maybe just to say that it's clear that phenotypic DST can only done in BSL-3 laboratories in the way that we do it now. So indirect phenotypic DST, first having a positive culture and then going towards the DST or MIC testing. And we know that there's also other options of doing direct DST. And I think this is something in the future to take into account to have a better rollout of phenotypic DST, amongst others on thin layer agar plates. But that's just a note aside.
Yes, thank you. And that will be a question we'll add to tell us that if there are any tools or diagnostic tools in the pipelines that can simplify phenotypic DST, and that will be something to consider. So thank you again, everyone, for joining us today for this session. Thank you for making the time, and thank you to the Gates Foundation for the funding. And as I mentioned, we will send the slides and the recording over to you, and you'll also receive a link to download your certificate of attendance. Thank you again. Good day.
Thank you. Bye.